Hello and a very good afternoon to everyone joining us online, to advocates, activists, researchers, and public health principals. Thank you for taking time to register and attending our webinar called Gaining Ground in the Fight Against TB today. A warm welcome to you all on this first webinar. I'd like to also welcome our panelists, Professors Sizulu Moyo, Neil Martinson, Ronelle Burger, and Joseph Daniels. And I welcome our moderator for this webinar, news editor at Health E, Ina Skosana. My name is Sihlema Hongandawonde, TB Accountability Consortium Project Officer. And today we have a full program ahead of us. And just to give you an understanding of how things will work today, we will have a short keynote by Sam Morn on the State of TB Report. This is the third edition of the State of TB Report, titled, What About Mortality? In this 2024 report, it focuses on the use of mortality rates as a litmus on where we are losing people on the care cascade and what other factors play a role, whether socioeconomic or other co-infections or morbidities in people dying of a treatable and preventable disease. We will then hand over to Ina Skosana, our facilitator for the panel discussion for the afternoon. Although our time's tight, please feel free to drop questions in the Q&A and the chat box, and the panelists will endeavor to answer those questions. We will also have time for questions after the presentation if time permits. Just to remind you, this is a webinar brought to you by the TB Accountability Consortium, which is an initiative of the Rural Health Advocacy Project, established at the tail end of 2021. TBAC, as we call it, is a growing platform of organizations centered on championing the increased coordinated action and for an advocacy agenda that increases accountability and transparency in the resource allocation, performance, and political economy at a national and provincial level for improved TB program performance. As the name suggests, this is a consortium of partner organizations, mainly the Treatment Action Campaign, TB Proof, TB HIV Care, as well as the SANAC TB Task Team, with the Rural Health Advocacy Project being a member and incubator of the TB Secretariat for the program coordination. Playing central to TBAC's two-pronged advocacy strategy is a local level activism component, as well as the data-driven advocacy for which we are here today. So without further delay, I introduce our project manager and lead researcher at the Rural Health Advocacy Project, Samantha Morn, who will be giving the keynote presentation on the State of TB in South Africa report authored by her team. Sam, over to you.
Thank you so much, Sihle. Morning, everybody. As Sihle said, my name is Samantha Morn. I'm the project manager at the Rural Health Advocacy Project. And today I'm going to be presenting the State of TB 2024 edition that we produce. I'm just going to see if I can share my presentation with you. Sure. Okay. Alrighty, if somebody could just confirm that they can see the screen, Sihle, is it all showing?
Yes, you're all good. Thanks, Sam.
Okay. Alrighty, so as I said, I'm going to be presenting the State of TB in South Africa. This year's edition is entitled, What About TB Mortality? For those of you who don't know, just a bit of background on the report. We produced this report to reach out to a broad group of stakeholders, right from policymakers to those in the general public. And the aim is just to create awareness of what issues need to be raised in terms of TB advocacy in South Africa. It also gives us an evidence base for our TB advocacy asks and directs those efforts so that we can help strengthen the TB program in South Africa. The report is quite extensive. I'm just going to be touching on key sort of points today. But if you would like to access the full report, you can make use of the QR code, which is on all of the slides, and that will take you directly to the full report. So I'll just get started. In light of all the significant TB mortality, both globally and in South Africa, we decided to focus this year's report on TB mortality. And the way that we went about it is to do a desktop review of peer-reviewed literature and grey literature to look at the TB care cascade and where there might be gaps in terms of, taking TB forward and reducing TB mortality and incidence. So just to start off, who is dying from TB? If you look on the right-hand side of your screen, you'll see a diagram that is the risk factors for TB as per the World Health Organization. And they include HIV, poor nutrition, alcohol abuse, diabetes, and smoking. When looking at gender, men are 1.7 times more likely to die from TB than women. And this is thought to be due to their lower participation in healthcare in general, but also in terms of their lower participation in HIV services. Furthermore, they also tend to smoke more and drink more alcohol than women do. And so that feeds those other risk factors into that side of things. From a comorbidities perspective, HIV and TB obviously have a significant interaction. And in 2022, globally, TB was the leading cause of death in people living with HIV. In South Africa, 57% of deaths are in people living with HIV. So there's a significant interaction there. And while antiretroviral therapy has made made a difference in terms of TB mortality, there is still, even with ART, there is still TB mortality happening in this patient group. HIV affects every level of the TB care cascade. So from how we screen patients with HIV, testing them, the treatment and the interaction between the drugs for the different diseases, and then also how we focus our prevention efforts. So it really does have a significant interaction. I think one of our speakers later in the program will be focusing more on that. And then in South Africa, we have this quadruple burden of disease. And with that, there's this interaction between communicable and non-communicable diseases, which became quite apparent during the COVID pandemic, but also plays a role in TB. So the diabetes is the second leading cause of death in South Africa after TB, but it also increases the risk of developing TB up to 3 times and doubles the risk of dying from TB while on treatment. So it also has quite a significant interaction. As I said, we had a look at the TB care cascade just to see where in the cascade things are going wrong. And just to see where in the cascade things are going wrong and where we can make a difference. Just moving on to that. So in terms of screening, what we noticed when we did the literature review is that, sorry, I'm just getting distracted by a message that came through from Sitle. What we saw in terms of the screening side was that there were missed opportunities to screen for patients. And then there were also opportunities, things where patients were missed during the screening process. So in the terms of the missed opportunities, that mainly had to do with healthcare workers where they didn't use the screening protocols according to the guidelines. They sometimes used their own questions. They found that TB screening could be overwhelming because of the competing disease priorities and their day-to-day priorities. They tended to prioritize HIV over TB in terms of screening. And they also found that the patient's attitude and behavior influenced whether or not they would be screened. So that presented opportunities that were missed for screening patients. In terms of where patients were missed during the screening process, this came about mostly because of the method of screening that was used. So in South Africa, we use symptom screening a lot, and that can be ineffective in identifying asymptomatic cases. The first prevalence survey, TB prevalence survey in South Africa found that 57.7% of patients were actually asymptomatic. And so symptom screening is not an effective way of picking up those patients. And there's a need to look at other alternatives like using digital chest x-rays. However, what we were just wondering in terms of, whether or not this is an effective way to use in South Africa is because what about the cost effectiveness of introducing this as a screening modality in South Africa? Is it a feasible thing from a cost perspective? And if not, what alternatives can we use? Then moving on to testing and diagnosis, This is a very key part of the TB care cascade, obviously, because we need to find cases, we need to diagnose people in order to get them onto treatment. And so it's really crucial that we find these TB cases and diagnose people as early in the disease progression as possible. That helps, obviously, to decrease transmission within the community. It helps with, getting people onto treatment. And then ultimately, because the severity of the disease is not as bad at that point, the treatment outcomes are better. So it's really key to find them early and diagnose them. One of the ways of doing this is the use of active case finding. What we found in the literature was that there was a finding that it was generally more cost-effective and more effective in terms of linking patients to treatment when this active case finding was done at facility level versus in the community or at home. And so, there were a number of reasons for that. One of them was because a lot of the patients that they were finding in the home-based setting were asymptomatic. And so they were more difficult to test, or we'll go into that a bit later. Another way of finding more TB cases is using targeted universal testing for TB. So this can increase diagnosis of TB cases as well. And for those of you who are not familiar with this concept, it's TAC for short. Basically, what it does is it not only looks at the symptoms, but it also looks at people that are at risk or have risk factors for developing TB and tests those people as well. So the screening then would include looking at people with HIV, people that have had previous TB in the last 2 years, and people that have had a close contact with TB, and then you test those people as well. So obviously this will help us to find more TB cases, but one of the difficulties that came up quite a lot in the literature was how difficult it is to get an adequate sputum sample in a lot of cases, and particularly in certain patient groups like those who are asymptomatic, those who have HIV, and in children. And so there is a need to look at other specimen types and how we can use those to test for TB. Currently, urine testing is used in HIV patients. They're looking at ways of testing stool for children, and then there is the potential for blood tests in the future to pick up TB as well. In terms of linkage to care, so this is obviously the next step. Once you're diagnosed with TB, then you need to be initiated on treatment. One of the things that came up quite strongly in the literature was the communication of the process of getting diagnosed between the healthcare worker and the patient. So how well that was communicated had a big effect on whether or not the treatment was initiated. What was found is that patients often didn't know their TB diagnosis. They didn't know that they were going to get an SMS to say that they, what their diagnosis was, and they didn't know what the next steps were to follow. And that all made them unsure what to do next in terms of getting onto treatment, and prevented that progression in the pathway. Another thing that we found in the literature was that there were certain factors that determined whether or not patients would come back to get their results or to continue treatment. And two of those factors included whether or not they thought they had TB or whether or not they had symptoms. And obviously that has a big implication for people that are getting tested under the TUTT guidelines, because basically, a lot of them will be asymptomatic and they might not feel the need to come back for their results, as they don't feel they have TB because they don't have the symptoms. And that really highlights the need for communication and counseling in terms of the care pathway from there. The other thing was that in South Africa, we don't have true point of care diagnosis at this time. A lot of it is still done in laboratory settings, even though the tests have the capacity to be point of care diagnosis. From a cost perspective, it was initially introduced in the laboratory setting. So this is tricky because what it means is that patients have to come back to get their results. And when they come back, that increases the cost of travel, the loss of income. And those are also factors that deter patients from returning and staying in care. And so it can decrease linkage to care. So those are just some things to look at in terms of linkage to care. When it comes to treatment, what we see is that females have a greater treatment success rate. So just to say the NTB strategy target is 90%. South Africa is sitting around 79% in terms of treatment success. But as I say, females have a greater treatment success rate. And one of the reasons that is proposed for this is that females are accessing healthcare services for other things, such as reproductive healthcare. And so they're accessing the services more frequently. Other studies, qualitative studies, were just speaking about how for males in particular, there was a stigmatization at work. There was a loss of a worry about losing your employment or losing income as a result of people knowing about your TB diagnosis. And so they wouldn't want to take time off work to go and get their treatment. Other factors that affected treatment success from a sociological perspective were poor knowledge of TB, travel distances to clinics, a lack of social support, and then food security. Obviously, financial circumstances all affected there. So those all impacted treatment success. And then integration of data systems was another thing that was cited as affecting treatment success. And this was really where there would be continuity of care, patients down referred from tertiary level to primary care or transferred between different facilities or different levels of the system, and there was no way to keep track of them. So integrated data systems would help a lot with that. And then having patient-centered services. So the CCMDD, which allows patients to pick up medications at points closer to their homes, obviously very helpful in increasing treatment success, but just to optimize those services and make sure that they're functioning in a way that patients can use them. And then finally in the cascade is just the prevention. So the focus here is the TB preventative therapy, which is, for those of you who are not familiar with the concept, it's where TB medication is used to treat people who have the TB bacteria in their body, but have not yet progressed to active TB. And they are given TB medication to then prevent that progression to active TB disease. The implementation of this program in South Africa has been suboptimal due to a number of reasons. The literature found that, we found in the literature that healthcare workers had reservations about the effectiveness of the TPT, or whether it was going to start developing resistance to the drugs. And so they were concerned about that and wouldn't prescribe it. Other things such as prioritization of TB and HIV treatment over prevention, and then the lack of education, not just of a community and patients, but also of healthcare workers in terms of the guidelines, was a problem. And then there were logistical issues, and those included things such as resource shortages and ineffective contact tracing, for instance. Other prevention strategies for TB include the BCG vaccine, contact tracing, preventing spread within health facilities, obviously the TPT, and then HIV prevention and treatment can actually be considered prevention of TB as well because of that significant interaction between the two. So that's the TB care cascade. We did also briefly look at other health system factors that aren't mentioned in the rest of the care cascade section. So we looked at a causal loop diagram that had been developed by Osman et al., which really spoke to the need for participatory leadership. And this is obviously thought it would be thought to improve TB outcomes just because it's collaborative, it increases buy-in from the patient, and it is patient-centered. And it's not generally the style of leadership that's employed currently. TB services should also be made as accessible as possible, and that's in terms of obviously geographical access, but also in terms of financial access, affordability, travel costs, that sort of thing, and in terms of acceptability with healthcare worker attitudes and waiting times and so on. So from all of these, we developed 16 recommendations, which I'm not going to go through in detail now. Again, if you would like to see them, you can access the full report using the QR code on the slide. But I'm just going to cover sort of 4 broad recommendations that do encompass a lot of the other recommendations that we included in the report. So the first one is just to address sociological factors when looking at the TB program and TB treatment success. Also to look at health-related factors like the comorbidities and the treatment of multimorbidity, integration of services, that sort of thing. The next thing would be TB education. So this would need to be improved for healthcare workers in terms of the guidelines, the protocols, but also for patients and communities. And then to make use of patient-centered care. So that obviously came through quite strongly in various different points of the care cascade in terms of having really effective counseling for TB patients, but also in terms of making the services as easy to access as possible, like the CCMDD, and optimizing that service. And then finally, the integration of data systems. Not only does this give us a good idea of what's happening, in terms of the TB program, but it also clinically allows us to track patients through the various levels of care and helps for that. So that's basically the snapshot of the State of TB 2024. Thank you so much for your time. And Sihle, I will then hand over back to you.
Thank you so much, Sam. And I'm sure that there will be other questions or comments pertaining to the State of TB report. Please don't forget to put those within the Q&A or the chat box. I'll hand over now to our webinar moderator, Ina Skosana.
Good afternoon, everybody. Thank you so much, Sihle. My part is quite easy. I get to introduce the amazing panelists who will discuss, who will take this discussion even further. So I think let's go straight to our first panelist, Professor Sizulu Moyo. Professor Moyo is a research director in the Human and Social Capabilities Division at the HSRC. Her work is focused on TB and HIV, where she successfully participated in numerous TB and HIV projects, leading multidisciplinary teams and working with local, national and international stakeholders and collaborators. Professor Moyo has led several national population level surveys, including South Africa's first national TB national TB prevalence survey. Professor Moyo, please go for it.
Thank you very much. And thank you, Ina, and thank you to the organizers for inviting me. I'm going to share my presentation and then I'll go straight into it. Hopefully I can find it. Okay, there we go. Let me know if you can see the presentation.
Yes, we can see it.
Okay, I'm going to just take my video off while I present. Thank you very much for the opportunity to join this webinar today. And thank you also for sharing the State of TB report in South Africa and also for the presentation that has just been given now. My talk really is looking at the burden of TB, just trying to understand what is happening as far as the TB landscape is concerned in South Africa. And I'd also gone on to look at how we may address the patient pathways to help us deal with some of the challenges that we're facing as far as TB is concerned. And I'm happy to say that quite a lot of what I had prepared has already been presented, so I'll be able to go very quickly over the presentation in that aspect. Okay, I'm trying to advance my slide. Let's see, advancing. I'm going to stop sharing and reshare again because it's not. Let me stop and then reshare once again.
And while Professor Moyo is doing that, I would just like to invite our attendees to please feel free to put your comments, your questions in the Q&A sections. Our panelists are available. They will be addressing questions that are relevant to them.
Okay, let's see if it's going to work this time. Can you see the presentation?
Yes, we can see it.
Okay. Is it okay? Is it in presentation mode?
No, it's not, Prof.
Okay, I seem to have a challenge to advance it if it's in presentation mode. Let me try once more. Okay.
There you go.
Fantastic. Okay. So I'm going to start by just talking about the burden of TB in South Africa. I'm sure most of us in this webinar have had a look at this information, but this is just to remind ourselves and take stock as we continue with this discussion and also anticipate the other talks that are going to come after mine. So this data is taken from the Global from the WHO Global Tuberculosis Report that was published last year. And it gives us, first of all, looking at the very first table on your right-hand side, the estimates of the TB burden in South Africa. I'm not going to speak to all of the numbers, but just to say that we have a high TB incidence in the country, estimated to be at 280,000 people who had TB in 2022. We have a lot of people who are HIV positive, who have got TB, and obviously we also contribute and feature significantly globally as far as drug-resistant TB is important. And the mortality aspects have already been discussed in the previous presentation. If we now move on to the figure that is to your left-hand side, the one that is showing the incidence, the new and relapsed TB cases notified, and the HIV positive TB incidence, looking at the rate per 100,000 population. What this graph is showing us is that we are making some progress. We see that the incidence is gradually going down. In fact, South Africa met its targets in 2020 in terms of reduction of incidence, but that does not mean that we're there yet. We still have a lot of cases, as we know that in 2022, there were 280,000 cases. But there is some progress and we're trending towards the right direction. If we look now at the bottom, I wanted to speak about the risk factors that contribute mainly to our TB burden in South Africa, and these have already been discussed in the previous presentation. But what I want to highlight is that when we think about how we may address some of the challenges that we have, it is important to bear in mind what is driving most of our TB in the country. Now, I also want to now look at two aspects that are also in the Global Tuberculosis Report, because these are very important if we think about addressing the gaps that we have. The first one I want to talk about is universal healthcare coverage and social protection. If we look at treatment coverage, which is calculated as the cases that are notified and the estimated incidence, in 2022, it was 77%, meaning that there is a gap of the remainder from the 100% that is not yet covered by treatment. And the next one, which is TB patients facing catastrophic costs, meaning that these are people who have a significant impact in terms of their financial status because of the TB diagnosis, which is more than 20% of the income that they had before that diagnosis of TB was made. We find that this is at 56% in South Africa, which is very high. So it has a bearing in terms of when we think about what we need to do in addressing the gaps and how we look through the interventions that we apply at different sections of the TB care cascade. So that 56% is something that we need to keep in mind. The last row, they speak about a TB case fatality, which is 20%, and we've heard a lot already about TB mortality. Then in terms of the outcomes, the treatment success rate for new and relapse cases registered in 2021 was 79%, not where we need to be. Those who were previously treated for TB is even lower at 60%. HIV positive cases, 79%, and for drug-resistant MDR, rifampicin resistant, and the pre-XDR and the XDR TB cases, it's not surprising. We know that we've got a lot of work to be done in this area, and these treatment success rates are much lower, just over 50% for those with pre-XDR and the XDR TB cases. Now, to further understand the TB burden and where our interventions may have significant impact, we need to understand which populations are most affected. And some of this carries through in terms of the people who are dying from TB, as was previously presented. I'm presenting two figures here. The first one on your right is what was found in the South African TB prevalence survey in 2018, looking at the gap between the cases notified and the actual number of cases that were estimated. And I just want to highlight three population groups. The men, the prevalence notification ratio was 1.89. the younger people, 15 to 24 years old, that was over 2%, and also the older people over 65 years old. And at that point, we estimated that about 154,000 people with TB were missed, meaning that they were not notified. If you fast forward to 2022, the picture has not changed that much. Yes, the number of people that were missing has declined, but if we look at where we are missing the people who have TB, it's pretty much the same. We are missing the older people. I've put a circle there, both men and women over 65 years old, and men in general. If you look at the notified cases and the incidents, you see the gap there that we're missing many men. They are going undetected, unnotified, and also children. There's cases that are being missed in children. And it's important to note that in the TB prevalence survey, the children under 15 were not included. So to understand our interventions, it's important to just think about the TB care cascade, and this has already been discussed in terms of the TB mortality, so I won't go too much into it, just to say that I'll just be referring to it as I speak to some of the coming slides. The first figure just gives you the generic care cascade showing where the gaps can lie and where interventions can then be implemented. And the figure on your left then shows you the South African TB care cascade for 2021. And what is significant there, what I want to point out, if you look at the people, the total TB burden, which was 304,000 in 2021, amongst all these people, less than half were successfully treated, which was 46%. So in terms of thinking about what we may do, it's important to think about the patient care pathway. And this is a slide that I took from work that was done by colleagues at the Stellenbosch University. And you can go and have a look at it because I won't be able to go through it in detail because of time. But it just gives you a picture of the pathways to seeking care, starting from, if you think about it, the very entry point of the TB care cascade at the population level, and the various factors that come to bear, for example, in terms of accessing care, what happens at the level of the service, what happens in terms of the diagnostic pathway, who gets diagnosed, and then in what happens further on down the line in terms of linkage to care, and further down in terms of adherence to treatment and retention in care and in treatment. So just understanding a little bit more about the patient pathways and where we may then have some interventions to address the people that who are missing. I'm presenting here, first of all, quite a busy slide, but what I wanted to show is that there are many areas where we can intervene as far as the patients or the people who have TB themselves are concerned. The very first bar chart that I'm showing you is data that came from the South African TB prevalence survey, where we found that people who reported TB symptoms did not seek care. So we know that symptom screening is not always very effective, and we know that symptoms do not always pick up all the TB cases, but they do pick up a proportion of cases, and it's important for people to seek care if they have symptoms that are suggestive of TB. So we can see from this survey that a lot of people did not take any action as far as their symptoms were concerned. If you look at the pie chart down at the bottom, amongst those who actually turned out to have TB and were symptomatic, just trying to understand why they did not seek care. The big one is a delay in care seeking. 66% said they were still planning to seek care. We also have those who did not regard their symptoms as serious. And we've got others, access barriers, the cost and distance, health system factors, and others in terms of fear of a TB diagnosis. I'm also showing you some data that came from the HIV survey in terms of what people know about the risk of TB. So generally, there are very high levels in terms of what people know who is at risk of getting TB. But what I think is striking here is that a lot of people seem not to be aware that people can actually die from TB. It was only 53% that we found in the HIV surveys done in 2017 and 2022. Another factor that also impacts the patient pathway in terms of seeking care is stigma. And some work has been done around stigma. And here I'm showing you what was found in the stigma index survey done by the HSRC, specifically focusing on TB. So what can be done is around demand creation. And it's encouraging that South Africa has now developed a social behavioral change communication strategy, because we know that we need to create demand. People need to know about the importance of TB symptoms, importance of TB, but then they also need to act on that so that they create demand and enter the cascade of care. And then in terms of improving patient pathways, looking at the health system factors, a lot of this has already been discussed by the previous presenter. And I just wanted to highlight a few things from a few studies that are picked up, and I know that there's a lot of evidence in South Africa. So starting first of all with some work that was done in KwaZulu-Natal by Murdoch and his colleagues, they found that there was inadequate and fragmented data systems. These also feed into mortality, inadequate screening, people not receiving adequate instruction about how to produce a sputum. And when those samples have been produced, also inadequate or poor handling. Some of them are leak, some of them are insufficient. So there is that delay then in reaching a diagnosis. If you look further down at the work that was done by other colleagues in Gauteng, there's also poor integration of programs. If you look at the work done in the communities by the community-based healthcare workers, and what happens in facilities, poor integration of programs, and also factors related to staff rotation and limited time for them to interact with patients. I've shown you the pie charts before. What we also found was that people didn't access care within the health system because they spoke about the facilities being congested and also staff attitudes which were not positive to them. And there's some work also that was done looking at mortality that found challenges around leadership, bureaucratic systems, poor integration, and lack of support in terms of supporting healthcare workers. So what can be done? Quality improvement is important. I know this is already going on in some areas. Integration of services and systems, adaptation to digital systems, issues around leadership, and also resource allocation. I just wanted to show the slide quickly to say that in terms of integration of systems, there are also many opportunities for addressing TB within the HIV care cascade. And I think it was also reported by the previous speaker that sometimes HIV care is prioritized over TB care. But when people access HIV services, there are plenty of opportunities for them also to access services related to TB. Another way in which we can improve patient pathways is around dealing with diagnostic delay. And this has already been discussed by the previous presenter. The issues around our screening methodologies. We know the data that came from the TB prevalence survey that a lot of people who actually had bacteriologically confirmed TB did not report any symptoms. They were picked up on chest X-ray screening. We are also aware of the targeted universal testing and treatment, and also the selection of appropriate testing. I'm just gonna end now with this issue around adherence, linkage to care and adherence to treatment and retention in care. And this is a very nice guideline that has been actually developed by the Department of Health, which really takes into account patient factors, and also the health system factors and the structural factors. And I think it's a good document for people to look at in terms of how we may improve patient pathways to link people to care and to retain them in care. I think that was my very last slide. So just in summary, we know that South Africa still has a high burden of TB. The declining incidence indicates progress, but mortality remains high. We have a lot of evidence for effective interventions, but implementation and scale-up of these interventions is important to improve patient pathways and also to close the gaps in the care cascade. That's the end. Thank you very much.
Thank you very much, Prof. That was really interesting. I feel like you could have gone on for so much longer. I'd also just like to direct your attention to some of the comments and queries in the Q&A box for you. And then while we do that, I would like to move on to our next panelist, which is Professor Neil Martinson. Professor Martinson heads the Perinatal HIV Research Unit at Wits University. His research includes preventing TB and measuring its interaction with HIV, viral drug resistance selected by PMTCT programs. Case finding for TB in HIV pregnant women and household contacts of a TB case. He has undertaken 4 large studies of household contact tracing using index cases of a variety of different types who either had TB disease or TB infection. Prof. Neil, please go ahead.
Okay, thank you very much. Can you see my screen and can you hear me?
Yes, sir.
Okay, thank you. So I'm going to be talking about really carrying on with the theme, finding TB patients too late. And tragically, finding them too late really implies that they have succumbed or have been admitted to hospital with critical illness related to their TB. And also a few words about the targeted universal testing for TB, which has been alluded to already. So just to start off with diagnosis too late. So the one sort of case study that I'd like to share with you is this story of people dying at home who die with TB. And in South Africa, about 30% of all people who die will die at home. And we thought that if the TB control program is not working, it's likely that a substantial proportion of people who die at home will have what is known as a garbage term as their cause of death. So these are terms that are non-specific and really don't contribute to being able to count causes of death so that you can intervene. And the garbage terms I've listed there. And over the years, the numbers of TB are clearly reducing in South Africa, and this is likely to do to antiretrovirals, more accessible TB diagnosis. There's been, I think, the RDP housing has created literally millions of houses for people to live in, which were an improvement on what they were living in previously. There's been an incredible expansion of the social grants, and all of these are likely to contribute to reducing tuberculosis, and particularly reducing the tragic consequences of tuberculosis, which is deaths. And one of the measures of deaths are these people who die at home without an apparent cause. And so in 2012, we did our first autopsy study, and again, we repeated it in 2019. And as you are aware, we had this massive COVID pandemic in 2020, which interrupted the study, but we continued to do it. And we did it in the same site in Northwest Province. And we identified possible people who died at home. There were quite strict criteria for including them. They couldn't have been admitted to hospital in the past 2 months prior to death, and that they shouldn't have had TB. They shouldn't be diagnosed with TB at the time of death. So these were people that we really thought, if the family brought a death certificate to be signed by a doctor, the doctor or the nurse would say, "I really don't know. I'm going to write unknown or natural causes or something like that." And so we did these what are called TrueCut biopsies, and this process is called a minimally invasive tissue sampling MITS, or sometimes known as minimally invasive autopsy, MIA. So we sampled the lung, we got bronchial washings through the trachea, and we also we took blood. And so here's a very brief summary of these 2 studies. The first study that we did in 2012, you can see is the middle column, and you can see that we excluded a large proportion of these individuals because they had existing TB. And then you can see that of the number we included, in 2012, we found 31% of these people who died at home had some evidence of TB. When we repeated this and we split this up into 2019, which was like a pre-COVID era, and then 2020, which was a COVID era, we found 16% and 17%. So if you just compare the 31.7, so it's 32% approximately, it halved 8 to 9 years later. And we think that that's probably a reflection of the improved TB program, improved social conditions, and markedly improved diagnostics for TB. And so that really is, we think, is a marker, one of the sort of sentinel populations of individuals that could be used as a marker of improvement in the TB control program. The second, this study is the first of 3 studies that I'm just going to share with you. And this is a study that one of the medical registrars at WITS did, looking at deaths at Chapong Hospital over the years 2017 to the first quarter of 2020. So relatively unaffected by the COVID pandemic. And you can see if you look at the causes of death that were based on a hospital record review, you can see that TB remains either the first or second rank in the strata of viral suppression. So even in people who by the South African definition would be considered virally suppressed, TB is either the second leading cause of death, and that's really quite worrying, because people who are virally suppressed theoretically are in care. They're being seen on a cyclical basis. They're being monitored, viral load and CD4 count, and one hopes that there's occasional TB symptom screening done. And for someone to have such severe TB that they need to be admitted to hospital for it and then subsequently die, one would have hoped that this could have been picked up prior. And you can just see, if you look across to the viral load greater than 1,000, you can see the proportion of deaths that had TB, and TB really, unsurprisingly, in these individuals really outranks any other causes of death. In another study that we have recently completed, we looked at admitted individuals with community-acquired, what they had a presumptive diagnosis of community-acquired pneumonia, and clearly a large proportion of individuals with community-acquired pneumonia in South Africa have TB. And so of those individuals, there were 30% were suppressed and 70% unsuppressed. So these are people living with HIV. And this was using a more strict definition of suppressed of less than 50, less than or equal to 50 copies. And in those individuals who were suppressed, we still had a very high proportion who died. And then of those who died, 13% died of TB, compared to the unsuppressed, where 22% died of TB. Now, that isn't a marked difference. It's not as though being virally suppressed has really protected these individuals from both TB and from dying with TB. And so that this is also quite a salutary signal to people who are responsible for the antiretroviral program. And this is just looking at the same study, but looking at the individuals that were admitted to hospital with TB. And you can see that of the people admitted to hospital, 75% were HIV co-infected. A large proportion of them, more than half, had some form of laboratory confirmation. And you can see the high rates of smoking and the high rates of alcohol use that may be contributing to these individuals having TB. And these are all patients admitted to hospital. So at the time of their ascertainment, clearly they were alive. Now, just looking at the ones with HIV, you can see that the median CD4 count is relatively low. More than half of them at the time of admission were on antiretrovirals, and you can see that the people with confirmed TB and were relatively high. So in the hospitals, at least, there's a large proportion have laboratory confirmation. But again, a quarter of these individuals were virally suppressed. And again, the people who are virally suppressed, really, it's almost a more tragic situation than people who are not virally suppressed, because these are individuals who have been diagnosed with HIV. The state has responded by providing them with antiretrovirals. They've responded by being compliant and being adherent to the antiretrovirals. And then despite this, they continue to be diagnosed with TB. And this slide in the same cohort of individuals shows the proportion that died in hospital by whether they were living with HIV or whether they were HIV negative. And you can see a much higher proportion with HIV died in hospital. A large proportion had died by 12 months following discharge, 12 months following admission. So this really shows that even if you get discharged from hospital, you still have a real risk of dying. There's a high risk of mortality even following your discharge. And so the mortality, the 12-month mortality, as I've said, is very high. There is a partial protection of being virally suppressed, but it's not complete. And really more needs to be done for people who are in care on antiretrovirals to ensure that A, they don't get TB in the first place, and B, that if they do get TB, it doesn't progress to become a critical illness. Now, in some of these individuals who we recruited to that study, we've also looked at a detailed assessment, the causes of death in hospitalized individuals living with HIV. So these are people who are admitted to hospital with critical illness. It may or may not be related to their lungs. And we did these autopsies in them, minimally invasive autopsies or minimally invasive tissue sampling. Autopsies combined with a detailed review by intensivists and infectious diseases clinicians. And so you can see here we had a sample of 59, not a very large sample because it's quite difficult to get consent and other things for these types of studies. And you can see that the majority were virally suppressed. There's a listing of the characteristics, but really, if I can draw your attention to the bottom line of this table, where you can see that just over half of these individuals who died in hospital were smoking. And clearly smoking is a risk factor for all death, but clearly a risk factor for TB. And you can see also the prior TB in the people who are suppressed, 42% had prior TB, where the unsuppressed, not such a great, about a quarter of them had prior TB. And prior TB is a risk factor for subsequent TB. Now, in this autopsy group, TB diagnosis was made ante-mortem. So while they were admitted to hospital, the attending clinicians diagnosed it, and then it was confirmed in as an underlying or contributing cause of death in slightly fewer than what was determined pre-mortem. And this is the first autopsy study where the autopsies show less TB diagnosed post-mortem than pre-mortem. And that, we think, is probably a good thing, that clinicians are, in inverted commas, overdiagnosing TB rather than, as they had in the past, underdiagnosed TB in people living with HIV. So then, just to get onto targeted universal testing for TB, which has been already shown, I just want to show you some additional data. And really, the underlying reason for doing this targeted universal testing is this more, I suppose, nuanced approach to trying to differentiate people with TB disease from so-called latent TB, and that even when people have subclinical TB, they may be transmitting. And there's increasing data from the Western Cape and from other settings, which shows that even if you have no symptoms, you still are producing culture positive sputum, and you are still producing viable bacilli in your breath or in your sneezes or your coughs or your talking. And so TUT was a cluster randomized trial of 60 clinics in South Africa randomized to receive targeted universal testing or not to get targeted universal testing. And if you look at the top table here, you can see the number needed to test to find one individual. You can see that overall, we needed to test 17 to find one person with TB. In people living with HIV, we needed to test 20. In people who are a recent contact of a TB patient, we needed to test 13. And in those with prior TB, in those who reported having prior TB, so this is not people who tell us they had prior TB treatment, but this is people who had been diagnosed with TB in the past 2 years and were not on TB treatment at the time of recruitment. Only 8 people needed to be tested to find one patient with TB. And here, unsurprisingly, you can see that being male gave you a twofold risk. If you had symptoms, clearly much higher risk for being diagnosed with TB. HIV infection, paradoxically, here was a protective factor against being diagnosed with TB, but not being on ART was really a huge risk factor. And in KwaZulu-Natal and the Western Cape, very high rates of TB compared to rates in Gauteng. And so overall, if you look at the bottom line of this table here, we think that doing targeted universal testing found 17% more patients with TB when you compared it to what was happening in the control clinics over time. So in the control clinics over time, every year there was an 8% reduction in TB being diagnosed, and in the intervention clinics, we were able to increase that by about 14%. And so overall, there was a 17% increase if you included the secular changes in this in TB in South Africa. And then just a last slide to say that clearly symptomatic individuals have a much higher proportion diagnosed with TB. And in all of these categories of people, HIV infected, the contacts, and also the prior TBs, but the people with HIV are really contributing the most number of people who would have missed TB if they weren't tested. So there has been a discernible impact of implementing TUT in South Africa, albeit that it's very variable in different provinces, and really we don't know what the impact on transmission, treatment outcome, or mortality will be, and there's more work to be done. And so thank you very much to my colleagues and to others that have contributed to this data.
Thank you very much, Prof. I'm sorry that we have to rush you so much. We really appreciate your presentation and your insights. I'd like to move on to our next panelist, Professor Joseph Daniel from Arizona State University. Professor Daniels is an associate professor in the Edson College of Nursing and Health Innovation. His research focuses on the development, implementation, and evaluation of social and behavioral interventions to address health disparities and foster thriving individuals and communities. Most of his work focuses on improving outcomes for HIV, TB, and cancer treatments among sexual and gender minorities, as well as cisgender men globally, with current research in these areas with collaborators in South Africa and the US. Prof. Daniels, please go for it.
Thank you, Ina, and thank you to everyone who organized this webinar, TBAC, and all of you for attending, and it's an honor to be here with the other panelists. My focus of my talk is really talking about caregiving practices, and I think this links nicely, or sort of dovetails nicely in the previous presentation. And looking at practices, caregiving practices by men and women, caregiving for those who are ill with TB, and then also doing treatment. And then really thinking about, can we really reevaluate gender norms when we think about caregiving? So I also just want to start off by saying that, all research, this is based on research, is in collaboration. And so my main collaborator is Dr. Andrew Medina Marino. He's at Desmond Tutu Health Foundation, and we do a lot of collaborative work around TB in Eastern Cape, particularly in Buffalo City Municipality. So we also want to thank BCM and the District of Health as well. So caregiving, what do we mean by this? So this is a non-healthcare provider, someone who's not trained as a healthcare provider. This person provides assistance with daily activities and may include sort of emotional support. The pool of caregivers is declining globally. And the question is, recently, do men do it? Do men actually provide caregiving? In the US, as a comparator, potentially, there are 16 million male caregivers for folks just in the aging, essentially. And so when we think about caregivers, we're talking about partners, moms, dads, go-go. We're talking about brothers, sisters, and friends. And when we think about male caregiving, it's often not labeled as such, largely because of masculinity norms that may shroud or sort of even stop men from actually doing caregiving acts or behaviors or activities. So we were interested in sort of understanding what does caregiving look like for men during TB illness and treatment, and particularly doing a comparison between men and women caregivers to men experiencing TB illness and treatment. The aim, this study around caregiving was nested in a larger cohort study where we were trying to understand men's and women's experiences during TB care and treatment. And we're interested in understanding key supporter or caregiver experiences and perspectives with caregiving for men with TB illness and in treatment. This builds on the previous presentation. So this is just one slide for the Eastern Cape. And as you see here, the number of TB incidents for men is considerably higher than for women. Not to say that the incidences for women is low, but there is in places, triple the number of new cases amongst men in the Eastern Cape. Again, it's a prospective cohort study. This involved a series of behavioral surveys. I will not present these here. And then also interviews. And then for what we're presenting here, we're presenting interviews amongst 48 key supporters of TB patients across the TB treatment cascade. We used a network individual model for our analysis, which looks at how tangible resources such as money, housing, food, and then also mental resources such as individual resiliency, empowerment, and support from others. What are these components when built together inform someone's treatment decision-making and persistence? And then we also employed a constant comparison approach during our analysis. 376 patients with TB, those folks doing treatment were in our cohort. And then, as I said, this is the breakdown by treatment stage, and 48 key supporters or caregivers we interviewed as well. We also did some work with nurses. So if you look here, amongst the sort of 45 key supporters or caregivers that we looked at, we focused on this 45. There, amongst the TB patients, there were 24 male patients and 21 female patients. And then you'll see the key supporter women and men here. And as you can see, there are male caregivers. There are more female caregivers. And the type of caregiver is listed below. So female relatives, male relatives, female partners, male partners, friends, neighbors, community leaders, and then female friends, and then male friends, neighbors, community leaders. So as you note here, there are no male friends, neighbors, community leaders that are providing caregiving to men or women. And then there are no male partners for male TB patients, and there's no female partners reported for female patients. We're mainly focused in this presentation on male TB patients, but we're also doing a current comparative analysis between caregiving experiences with female TB patients, but I won't report that here. So the few themes that we identified, fathers and brothers, they did provide tangible resources, and some served as sort of confidants with limited burden. They didn't, most male caregivers didn't describe necessarily a burden in both emotional and resources that they provided for their caregiving. So, for example, as this quote says, most of the time when he needs something, he talks to me. For example, when he needs vegetables, he talks to me. He doesn't have anyone else to share things with. This is a brother of a male TB patient. And then another brother, sometimes you will find out that he feels cold and needs a heater. So I had to go buy paraffin for the heater. I was also giving him food when I have money. And another father of a TB patient decided to take care of his 2 kids while he was completing his treatment. So the children went to the father's home. Conversely, women family members demonstrated more routine, emotional, and tangible care, and they also described considerably much more financial impact on the household and time burden to their care when compared to how men describe their caregiving. A mother of a TB patient, she says, I know when you are ill, you lose appetite, so I always encouraged him to take small portions of food. I kept his treatment so that every time after finishing his food, I would give it to him. Another thing that I always consoled him, we're not only taking care of him, but his children as well. So from this quote, you can tell that she is, actually minding or encouraging him to take his, or reminding him to take his treatment. There is food involved. She's actually managing the treatment in that she's actually keeping the treatment for him. And she's also noting that they are taking care of the children as well. So women caregivers in this case seem to have a more sort of broader, sort of multi-level caregiving approach when compared to men at this time. So what have we so far learned from our study so far? We do need to engage men more because men do engage in caregiving, and then also potentially distribute the risks of caregiving. Women described also, I forgot to mention, that they will reroute money, like for example, school fees to support those in TB treatment. And they will also take out loans from loan sharks also. They're more apt to do that when compared to men. So they do describe the financial burden more so than when compared to men. So, we do see that men and women care for men in different, they do care for men, but it does look different, but caregiving is occurring. The manhood norms seem to suggest that they're providing more tangible support rather than emotional support. But we do note that men are serving as confidants to other men, particularly during treatment. And this may be an opportunity to distribute risks away from women who also provide the caregiving. Women's role for caregiving seems to be more routine, daily. It involves more multi-level, such as children, food, and dosing, and also the financial risks that women discuss in compromising the household. But we still need to understand several things. What does caregiving look like for men during TB illness and treatment? I think we need to understand that more. Our sample size for men providing caregiving is still quite low. And then how do we maintain the well-being of caregivers? We do see stress and emotional burden for caregiving, particularly amongst women caregivers. And how do we develop interventions or programs to support caregiving in the household, which is so essential given that I believe a significant portion of folks pass away in the home due to TB. There's more to be done in the analysis. Like I mentioned before, we're looking at comparing men and women TB patients and their experiences with receiving caregiving, and then also if there's differences by gender with regard to the type of caregiving provided. I want to thank all these amazing people in South Africa and globally, our research team, the participants for sure in our study, and BCM, District of Health, and particularly in Dubai, Rene, the nurse director. I'll leave it at that. Thank you so much.
Thank you so very much, Prof. Prof. Daniels. I don't know how you got all of that done and actually answered questions I didn't ask in such a quick time. Thank you. Moving on to our next speaker, please, Professor Ronelle Burger. She's a professor in the economics department at Stellenbosch University. Her interest is in poverty and inclusion in African countries with a focus on the role of health inequities. Her research is closely aligned with policy process because it aims to inform and support initiatives to fight inequity and address problems with healthcare delivery. She's a board member of the Journal of Development Studies and an associate editor of Health Economics. I think we'll end it there. Thank you very much, Prof. Please go for it.
Thanks, Ina. Can everybody see my slides?
Yes.
Fantastic. Firstly, I want to echo what the other speakers have said and just thank the TB Accountability Consortium for the invitation and also for this very useful forum and all the incredibly interesting presentations and sharing of information amongst like-minded individuals who all care about this disease and wanting to sort of gain ground, like the title suggests. Our work recently is situated in the space between research and advocacy in a way. This work has been done in collaboration with the Accountability Consortium and has originated from conversations amongst researchers and thinking through the contributions that researchers want to make and aspire to make to move the TB agenda forward, but also to accelerate learning and to accelerate problem solving. So acknowledging that we are currently facing a time of transition, and this time of transition includes shifts in the TB patient profile, shifts in the TB mortality risk factors, innovations that have opened up brand new options for diagnosis, prevention, and treatment. In South Africa and also globally, it includes changing social, political, and funding landscape. And then, of course, we should acknowledge that the shifts include, but also exceed the pandemic. And in this new landscape that has both new opportunities and new challenges, it is particularly important, we want to argue, to ensure that we have optimal access to TB data and that we mobilize and divert energy to promote optimal access to TB data. The rationale for it would resonate with all of the researchers and I think also the activists and the practitioners in the audience and the policymakers within the context of uncertainty and shifts in the landscape. It's incredibly important that we accelerate iterative learning, that we learn what works within these new parameters. And data helps us to adapt faster, to solve new problems and roll out new solutions. On a macro level, of course, data can also promote transparency and strengthen governance, democracy and accountability. And from an equity and social justice perspective, for us as development economists, it's also very important to stress that granular regional facility level data can help us understand resource allocation and help us look not only at sort of aggregate outcomes and aggregate targets, but look at equity and resource allocation. And these things are urgently needed in South Africa, especially recently with the tighter constraints on government spending. And I want to echo also what Sam and the report has found in terms of the need for more cost-effectiveness studies to help inform prioritizations, given that difficult decisions need to be made at the moment, not only because of new options emerging, but also because of the tighter fiscal space we have. All of this happens against the backdrop of our country's PAPIA legislations. And the issue that we've identified here is that PAPIA can impede the sharing of valuable health data, even in a context where there is minimal reason for PAPIA to indicate that data should not be shared freely, such as is the case for most facility level data. There have been a shrinking of the space for freely sharing such data. And what is reported is that policymakers often gravitate towards minimal risk-taking. They have a choice or decision space between what is permitted and what is required, but often the gravitation is towards sort of the minimal risk, which means that the minimal is provided, and this has substantial adverse consequences for researchers, but also just for society in terms of accelerating learning at a critical time that we are in now. Specifically, we also want to flag with this this work and the report that we hope to release soon, the opaque and long data access processes that are disadvantaging not only the research community in general, but specifically people in need of information and data with weaker links to research and data hubs. And those might be young and emerging researchers, and also non-government practitioners and advocacy organizations. Shifts in the availability of data should also help data systems to facilitate health workers better. In our work, we frequently encountered complaints about facility health workers struggling to do their work as well as they want to because they can't access the data that they need from the system. In one of the facilities where we're working at the moment, the TB nurse is keeping separate Excel data records of patient TB outcomes because she struggles so to access the data in the system. Just as an example. What our vision is, and this is a consultative exercise and something that's collaborative. So these are our first thoughts in the report, but our vision is to maximize the availability of data, while of course respecting moral and legal limitations due to privacy. We want to promote the following of best practices. The ideal would be facility level data that's downloadable from a repository with minimal delays and minimal paperwork. And overseas, there are many examples of that being rolled out and working well, including the NHS. There are credible systems in OECD countries, but also developing countries. And in some cases, it might be required to have application processes, but I think advances and promotion of more transparent application processes, not only in terms of what needs to be done, but also waiting times and optimization of rapid processes, and a deprioritization of dashboards and hard copies that impede waiting times for data. And also transparency in terms of what is available to the research community and to the practitioner community and how it has been generated and processed, so that there can be a deep understanding of the data that we're looking at. I think what is very promising and encouraging is that COVID has shown that we can do beats in terms of the rapid release of data, and we can expect more. I also, I want to echo what Sam has said in terms of the crucial shifts that are needed. I think in terms of data analysis, in terms of understanding, a lot of what we're missing at the moment is putting TB patients at the center to really understand who are our TB patients. The presentations that have been presented here today have been fantastic to listen to, and I think they are starting to address that problem. I'm not saying that we don't know, that there's not a lot that we already know, but I think there's a lot still to learn. We need to understand our TB patients better. We need to understand who we miss. And specifically understanding TB deaths and deaths amongst patients who are not notified and not on treatment. This is important also because of concerns regarding the large shares of asymptomatic patients. We need more longitudinal data and more qualitative research on patient deaths to understand patient stories and journeys, not just snapshots and cross-sections, but really understanding, how the system served or failed the patient, understanding their backstory, understanding their family story, to have a better grip on how we close the gaps and how we address the impediments that lead to avoidable deaths and missed opportunities. And particularly, I want to echo the previous speakers in saying that the understanding of the full patient is really pivotal. We need to understand the social, economic, and personal factors and how they contribute to unsuccessful treatments and TB deaths, and move towards formulating and experimenting with approaches that look at the patients not just through a medical lens, but acknowledge all of the different challenges that they face and try and support the crucial ones that we can see are impeding the successful journeys and are most likely to increase the risk of death. I think I'll end here. I have more slides, but I know I am running out of time. I want to leave some time for questions at the end. It's very important, I think, given sort of the shifts in the landscape that we're seeing, to just more broadly create spaces for local learning. And the idea here has been advanced by people like Matt Andrews and Lance Pritchard, that we need environments within organizations that encourage experimentation. We need to try new things, learn, fail fast, iterate and adapt. Given how many moving parts there are at the moment in the TB space, I think it's important to provide freedom for learning and for closer and more iterative feedback loops. And of course, data is very crucial. More rapid access to data, more granular access to data is very crucial in this process. I wanted to highlight the gaps between written policies and how these policies are implemented. In our previous work on simulated patients, for instance, we found that when we trained the TB mystery patients, the simulated patients on the protocols, it took an hour to fully implement the TB policies for screening and testing a TB patient. But when we took those simulated patients into the clinics, what we found in the clinics is that often nurses had only 5 minutes. And these TB guidelines often don't have any prioritization. And I think it's important to close those gaps. That's just an example, in terms of how policies are written and then the implementation context and what the implementation context allow. And feedback loops and better data, creating spaces for data on community experiences and clinics to bubble up into the meetings where these decisions are being made often. All of these things I think are very valuable, and I think things that the advocacy and practitioner audience who are attending this meeting will probably also find to be very valuable and very close to their heart. I think these are the main things. We're hoping to release the report soon, and we would appreciate all of your inputs and your comments on championing easier and better access to data and having conversations about how we navigate PROPIA carefully and responsibly, but without closing the space for rapid access to data that can promote our attempts to gain ground in the fight against TB. Thank you.
Thank you so much, Prof. Colleagues, this has been such an insightful discussion, and unfortunately we are running out of time and we will not be able to address any questions in this particular session. But I really just want to go back and say, Prof. Moyo, Martinson, Daniels, and Prof. Burger, thank you all very much for taking the time to put together these insightful conversations and presentations that are understandable to people beyond your areas of expertise. I think it's so important to remember the various facets of life that a disease like TB affects. And hopefully by addressing some of these problems, we would be able also to address wider health systemic issues. With that said, thank you to the panelists, and I would like to hand over back over to Sihle, please.
Thank you so much, Ina. And thank you to all the panelists. Obviously time has run away with us, unfortunately, but we're hoping to continue the conversation during the 8th SA TB conference that's going to be happening in Durban, where we're going to be having a satellite session during that time as well. So I'd like to again thank our speakers, and thank you for Ina for being our moderator, and for everyone who's joining in this webinar. Thank you so very much. Take care, and if you would like to see any of our publications, please go into www.tbac.org.za. And from me, thank you so much, and do take care.